Good morning, everyone. This is Leora Fox from the National Offices of HDSA, and I'm here with Dr. George Yorling. And we want to welcome you to our May edition of the HDSA Research Webinar Series. And today we're going to be talking about exercise with Dr. Lori Quinn from Columbia University. And before we begin, I just want to remind you of how you can how you can ask questions during this webinar. Your questions will be answered after the presentation, but you can send a question anytime. So you just want to go to the right side of your control panel. It should say questions, and there'll be a panel there for typing one in, and then you can type one and hit the send button. And then at the end, we will field those questions, and Dr. Quinn will answer them for us. And I want to remind you as well that to view this webinar again, or perhaps to send it to somebody who couldn't today, it will be available about a week afterwards, and you can access it either on HDSA's national website at hdsa.org/researchwebinar, or you can go to our YouTube page, which can also be accessed at the top of our hdsa.org main page. And you can see this recording or any other ones from the past. For our next month's webinar, we're actually doing a live stream at our convention for the Research Forum, which is on Saturday, June 9th, and that will begin at 9 a.m. Pacific Standard Time, so West Coast time at 9 a.m., and there will be presentations with some breaks until noon. And you can go to www.hdsa.org/convention, and that's where you'll find the link to tune into the live stream for that. So I would now like to introduce Dr. Lori Quinn, who is an associate professor in the Department of Biobehavioral Sciences at Teachers College, Columbia University, and she also holds a joint appointment as lecturer in rehabilitation and regenerative medicine, physical therapy at Columbia University Medical Center, as well as senior research fellow at the Center for Trials Research at Cardiff University in Cardiff in the UK. Dr. Quinn has worked with people with Huntington's disease since 1991 and is currently a consulting physical therapist and clinical researcher at Columbia University's HDSA Center of Excellence. She has conducted multiple clinical trials evaluating the benefits of exercise and physical activity in people with early and mid-stage HD, and is currently the co-principal investigator for PACE-HD, which is a multi-site study that's currently underway in Europe and the US. So thank you very much for joining us, Dr. Quinn, and I am going to hand it over to you.
Okay, very good. I will just share my screen. Okay. Is that working? Can you? Yeah. Okay, very good. Well, thank you very much, Leora and George. Thank you for inviting me to come and speak. I'm going to be presenting today on exercise for the brain and body, the benefits of physical activity in Huntington's disease. As Leora mentioned, I am a physical therapist. I'm right now at Columbia University, and I was at Cardiff University in the UK, where I lived for 11 years with my family. I actually lived in London, and I worked at the Center for Trials Research there, where we conducted a lot of the studies that I'm going to be talking to you about today, and I continue to collaborate with the group at Cardiff University. I actually started my work in Huntington's disease back in the early 1990s, working at a nursing home that specialized with individuals with Huntington's disease, and now the work that I do is at the HD clinic at Columbia University, where we see patients at all ranges of the disease spectrum, from pre-manifest all the way through to late stages. But what I've been really interested in the last few years is trying to identify the exact mechanisms of exercise that we think might be helpful, not just in helping people with improving function and day-to-day activities, but also in potentially helping to slow the disease progression. So one of the big emphases that we have is to work with people in the very earliest stages of the disease. So what evidence do we have for exercise as a therapeutic strategy or an intervention for people with HD? And I certainly know we're we're all aware of the great progress that has been made for pharmacological interventions. But exercise and physical activity in HD and in other neurodegenerative diseases is really showing to be a very powerful intervention in and of itself. About 15 years ago, we only had a few sort of anecdotal reports about exercise, some case studies, some what we call expert opinion of individuals, kind of working with people with HD and saying, yeah, we think that exercise actually helps, but there wasn't really good quality evidence to show that exercise was beneficial. And about 10 years ago, we started to have a few more. We did some work with the European Huntington's Disease Network, and also the Huntington Study Group has been supportive of the work, where we tried to identify developing guidelines for physical therapy, again, starting some really early preliminary studies, getting therapists and client views about exercise programs, and trying to determine outcome measures. And this early work has led us over about the past 8 years to conduct a much larger number of what we call feasibility and relatively small short-term studies on the benefits of exercise and physical activity. And this has been a tremendous increase, just over these past years of what we've been able to do. Just recently, last year, we had enough literature that we were able to publish what's called a systematic review. So we were able to take the research that's been done over these past few years and try to analyze it systematically to say, is there any consistent evidence to show that exercise and physical activity is beneficial? And so we just published this study in the Journal of Huntington's Disease, where we looked at 18 studies that evaluated in some form exercise or physical activity. And what we found was that there was preliminary support for the benefits of exercise and physical activity in terms of a few aspects. So specifically motor function, gait speed, and some other aspects that were patient-reported improvements. One of the things we did find is because the studies were so heterogeneous, they were so different, they aimed at very different things, that there were improvements in some things on some studies and other things on other studies. So physical activity was actually something that improved with some patients. There was some studies that showed that function improved, but it really was a bit study dependent in terms of what was being shown. But what we do know is that there is definitely preliminary support for the benefits kind of cutting across a range of motor functions. So what are these different types of exercise that can be done? This is the activity pyramid that I like to show a lot, and we're going to come back to this at the end because it kind of gives a quick visual about the different kinds of exercises and activities that are out there. So if you look at the very bottom of the pyramid, one of the general concepts about exercise is that every day you should be striving to move more and sit less. And I will certainly say the caveat that this really applies to anyone and not just people with HD or with neurodegenerative diseases. But we know from a lot of different studies that moving more and spending less time sitting is good for you. So, and this is what we generally call physical activity. So taking extra steps in your day, walking the dog, taking the stairs instead of the elevator or the lift, parking your car further away, just getting in activity. If we go to the next level up on the pyramid, we have aerobic exercise and recreational sports. And a key aspect of this is the aerobic benefit that you get from engaging in exercise where your heart rate increases. And this is something that's recommended, again, for the general population to be done 3 to 5 times a week. And aerobic exercise is something I'm going to talk about next, where we think it really has the potential to have a neuroprotective effect in HD. And the next level up is something that we recommend doing 2 to 3 times a week, which is strengthening and stretching or resistance exercise, and also other leisurely activities. Strengthening exercise, we think, is really important in HD because we know that people, as the disease progresses, can lose muscle strength. This has been demonstrated. We don't exactly know why that is, It's possible that it's inherent to the disease, and it's also possible that in combination it could be because people are less active and thus they start to lose muscle strength. So strengthening and stretching and flexibility exercises are really important to counteract some of the effects with HD. And then at the top of the pyramid, again, something we all struggle against, I think, is sitting sparingly. So this kind of gives you just a general overview of the kinds of things that you should be doing with regards to physical activity and exercise. And I'm going to specifically be talking about some studies that we've looked at that have looked at aerobic exercise, and then down at the bottom, that long blue piece about what physical activity might do. So let's first talk about aerobic and resistance training. The first study that I want to talk about is a study that we completed a couple of years ago called Exert-HD. And this was a study that was conducted in Europe. We worked with 5 different sites, and we enrolled 32 participants. And we did a randomized controlled study. So in a randomized study, you take a whole group of people, and half the people get randomized to the intervention, and half get randomized to something else. And in this case, we had a control group. Because at this point, we haven't demonstrated that exercise could be beneficial, and in fact, we didn't know even if it could be harmful. We had a control group that just continued on as usual, and then at the end of the intervention, they were able to get a smaller component of the exercise intervention. So we had patients come in for 12 weeks, 3 times a week, and what we had them do, I'll just make sure that this is. I don't know if I can lower that, but you can see that individual who is biking and actually looking very happy. But this was an aerobic exercise component where patients rode on an exercise bike for almost 30 minutes. And they had their heart rate in an aerobic zone. And you can see if they weren't able to use this bike there, they could use a recumbent bike that you could see there below. And then the other piece that they did was strengthening and stretching exercises. So 15 minutes on key muscle groups. So we had them doing sit to stand, squatting, lunges, and even planks, if anyone's familiar with those. So what we saw with this study was that patients had improved fitness. So you can see at the graph here on the right-hand side, this was at assessment 1, at baseline, what individuals' fitness was, and then you can see at baseline 2, the significant improvement in people who were in the intervention group from the baseline to the second assessment, whereas the individuals who were in the control group remained stable. And that was a really highly significant difference in improved fitness. And this is how we measure fitness here, is by having people have a mask on, and we can measure specifically something called VO2 max, which is a measure of fitness. But the other thing that was really exciting, probably most exciting for us, is that we saw an improvement in motor function as measured by the UHDRS, which is the Unified Huntington's Disease Rating Scale, that modified motor score, which is kind of the best measure that we have right now as an indicator of motor function that's related to the disease. And we saw that people who were in the intervention arm actually on average scored almost 3 points lower than those who were in the control arm. And this was just after a 3-month intervention. So we were really incredibly encouraged by these results, that exercise, and specifically this aerobic and strengthening combination, might have an effect on the disease-specific motor function. So why do we think that this is? Well, there's a lot of concept that aerobic exercise and in combination resistance training and even goal-based exercise, which you can see up here, can have a neuroprotective effect. And the way that it does that is sort of twofold: by improving the synaptic strength, so it actually creates new neurotransmitters to be formed, and it increases specific functions within the brain that allows for better synaptic connections, so the signaling within the brain. And also we believe that it has improved brain health. So just overall having that increase in blood flow, which goes to your brain, can result in improved immune system, an increase in what's called neurotrophic factors. Those are sort of protective factors within the brain and that create new synaptic connections and neurons. Developing these new neurons and just increasing the metabolism will increase the overall health of the brain. These together can strengthen the circuitry that is critical for movement, and that is partially damaged with Huntington's disease, and specifically within the basal ganglia. And this then can result not just in improved function, but actually improved motor abilities and potentially cognitive abilities. And we certainly know that exercise can have a really positive effect on mood and motivation as well. So that's kind of the mechanism about aerobic exercise and strengthening. And I'm going to talk in the end about a study that we have going on that's going to look at this a little bit further. But what about just physical activity? So, just is it okay if I don't like going on a bike, or if I don't like doing aerobic exercise, is it okay for me to just walk around and just go for long walks and not sit too much? Is that going to be okay? So one of the difficult things about exercise, in general, is that it's difficult for people to do it. It's great to be able to say, oh, go out and exercise, but it's hard. It's hard to get motivated. And this is a really famous saying from Dr. Robert Butler, who's at NIH, who said if exercise could be packaged into a pill, it would be the single most widely prescribed and beneficial medicine in the nation. We believe that exercise is like a medication and can be thought of like a medication, and trying to reframe it and thinking about it as something that can be as potentially as beneficial as taking a pill, may be one of the ways that we try to get people, over the hump of getting engaged. But this aspect of physical activity we have looked at with a study that was completed again a couple of years ago called Engage-HD. And in this study, instead of giving people very specific exercises to do, we said, right, let's just see if we can work with people to see what it is that they want to do, what works within their lifestyle, within their work schedule, their home life, and try to get them to engage in any kind of activity that they will be able to actually do. So we did this by looking at three components. We had a coaching program where we developed a workbook where therapists work with patients through this workbook to try to develop and set goals around physical activity and figure out activities that were going to be most beneficial and work within their lifestyle. The coach, who was a physical therapist or in some cases was either a nurse or a trainer, worked very closely with the patient in a method that was very much non-judgmental, was really just trying to promote what their best interests were, and not being, not telling them exactly what they had to do, but again, working within their lifestyle. And then we had options for different programs that patients could participate in, such as we had developed an exercise DVD that could be used in the home, and we also developed a walking program. So we conducted a 2-arm, again, randomized controlled trial where patients got randomized either into this intervention group or into what we called a social contact control. So the comparator for this was we had individuals who were in the social group just sit and have a good chat with the therapist, and they talked about various topics of interest that were of interest to them, but they didn't specifically talk about physical activity and exercise. And that was to control for the contact time, because a lot of people just enjoy being around a therapist or a trainer, and they might have perceived benefits from that, but they weren't necessarily going to be related to physical activity. So patients had 6 sessions over 14 weeks, and we compared those, the physical activity with the social contact. And we had some really nice results in this trial as well. We demonstrated that people improved their self-efficacy for exercise. So they had a greater belief that they could actually engage in exercise and knew what they they could do and what needed to be done. They actually increased their physical activity and something called their life space. So that means they kind of got out of the house and out of their immediate surroundings more than they had at the baseline. And the other finding that we had, which was really surprising and interesting to us, was that we demonstrated an improvement in cognition in something called the symbol digit modality test, which is a test that's frequently administered in the Enroll battery. And so that was very encouraging to us that because of this physical activity, patients might have then had a knock-on effect of improving their cognitive ability and been able to think a little bit more quickly or more clearly. And this is certainly something that's been shown in other diseases in healthy individuals, but we hadn't been able to show it in HD until this time. So the last form of exercise that I want to talk about is something called multidisciplinary rehabilitation. And this is not actually work that I have done. It's work that has been done by other individuals. And actually, it's work that hasn't been done in the United States. And when I show you about it next, you will see why it hasn't been done in the U.S. Multidisciplinary rehabilitation has been conducted in places like Norway and in Italy and in Australia, where people with HD have been admitted over the course of a year at 3 different time points. So in this particular study, patients were admitted 3 times within a year for 3 weeks period. So they actually went into a rehab center and they stayed in hospital for these 3 weeks. And during those 3 weeks, they got very intensive rehabilitation, what they called multidisciplinary rehabilitation. So it wasn't just physical therapy. It was physical therapy, or as they call it there, physiotherapy, occupational therapy, they had speech therapy. They had group outings, group therapy. They worked with social workers. So basically 8 hours of various activities, 5 days a week. And they did this in small cohorts of 4 to 6 individuals. And then they had a range of assessments that were done before and after each intervention. And you can see here in this picture how absolutely beautiful this rehab center is in Norway. And they had swimming pools and lots of different activities for them to do. And there was some really interesting results from these studies. And again, this is just one of them. There's probably been about 3 or maybe 4 multidisciplinary rehab studies that have been done. And in this particular study, they demonstrated improvements in a walking test called the 6-minute walk test, where patients were able to walk much further after the intervention. They showed improvements in balance and in quality of life that was related to physical functioning. They also improved their anxiety and depression and had improvements in their body mass index. Interestingly, in one of the studies, this is the one that was done in Australia, they also did brain imaging of individuals after they had undergone the multidisciplinary rehabilitation. And what they showed was a relationship with the improvements in cognitive ability that was seen in this study with changes in gray matter volume. So there was actually a correlation with the sort of functional and day-to-day improvements that they saw with improvements in brain structure. And that was something that it was a small study, and I will caution you that there was one of the issues with the methodology of the multidisciplinary rehab studies is that there's no control groups. So it's unclear what would happen to individuals if they were not part of this, or if there was some other matching for contact time, but they didn't do these exact things. And that's a really important part of study design. But these do provide really important preliminary evidence that this kind of intensity of rehabilitation might actually have an effect on disease progression. We certainly don't expect people naturally with the disease to improve their walking ability. If anything, they might stay the same or maybe, certainly start to get worse over some period of time. But these studies are showing that it's possible to slow and maybe even halt the disease with the right kinds of exercise and stimulation and activity. So this brings me to where we are with our current studies. So I'm going to just highlight 2 current studies that we have going on right now. The one, Preactive HD, which was funded by the Huntington Study Group, is an ongoing feasibility study. We're just at the tail end of this study. We're recruiting 14 individuals with pre-manifest and early stage HD. So as I mentioned in the beginning, one of our big efforts now is to work with people who are in the earliest stages of the disease to see if we can have a disease modifying effect. So we're evaluating the feasibility and acceptability of a coaching program in these earliest stages. So we're working with people who, in theory, don't really have many symptoms, if any symptoms at all, but trying to get them engaged in exercise before these symptoms start to come on. And what we're doing is using 4 sessions delivered either in person in our lab here at Columbia or via video conference. So we have some people that we're administering this to who are completely remote, and we're doing it all kind of over, video conferencing. We have modified, based on our previous study, the physical activity workbook. So this is our version 2, and we have a US version. Actually, we have a UK version. We have it in Spanish, and we have it in German. And so this is, again, this workbook where we use goal setting, and we educate people about a lot of the benefits of exercise and physical activity. And kind of the really fun part about this study is that we're having individuals use a Fitbit. So everybody who is in the study gets a Fitbit. You can get, if anyone has not used a Fitbit or hasn't seen these, they're very, kind of easy to wear. They're almost like modified watch. And they do keep the time. You can actually get, text messages and other things through them. But they're relatively easy to wear right on your wrist. And if you have a smartphone or even on a computer, you can have access to a lot of information that's actually relatively accurate about your daily physical activity. So things like steps, how many miles you walked, how many calories you burned, how many floors you climbed. And a big thing that it really does for us is we get heart rate from this. And we can get an understanding of individuals' intensity of exercise and activity throughout the day. And this will help us to start to tease out that question of how important intensity is for exercise. And so this study, as I said, is ongoing. And the other big scale study that we have going on is called PACE-HD. And this is a study that's been, it was funded by the Jacques and Gloria Gosweiler Foundation in Switzerland. And it's very well supported by Enroll-HD, and the Huntington Study Group is collaborating with us on the study. And we are enrolling 120 people with Huntington's disease at 6 sites. So there are 2 sites in the US, one at Columbia and one at UCLA in Los Angeles. There's 2 sites in Germany and then 2 sites in Spain. And this is a multi-site study, again, of exercise and physical activity, but we have a slightly unique study design that I just wanted to review with you. So we have people come in and we screen and we recruit them. And in half of the sites, so 3 of the sites, the individuals just continue on as normal. So we do a baseline evaluation, and then we send them away and say, do what you normally do. But we keep track of them, and we ask them questions when they come in at this 12-month assessment. And we can see sort of what the natural progression of physical activity and mobility will be over this 1-year period. But then we have the other 3 sites conducting this a randomized control trial, so similar to what we've done in the past, where we break people down into a physical activity intervention group and activity as usual. But the difference with this is we're doing the intervention over a much longer period. So the intervention is lasting over 1 whole year. So individuals in this study will actually get 18 physical therapy sessions over the course of the year. And will also be encouraged, using the workbook and using the coaching approach, to try to engage in exercise outside of the physical therapy sessions. So again, it's a combination of this real emphasis on aerobic exercise, but also in improving physical activity and day-to-day movement. So many of you might be asking, what can we do now? What can my loved ones do now? What's really the most important thing? What are the take-home messages? Well, going back to that activity pyramid, I don't think you can go too wrong here. We don't know yet the exact details of the best optimal intervention. The other thing I wanted to quickly mention was HITS training. If anybody's heard of that, but that's high intensity training. There was a study that came out last year that looked at this really high intensity, like 90% of your heart rate max, it was really aggressive, but they showed some nice improvements in fitness and potentially some in motor function. So we don't know if that's better, or if biking is better, aerobic exercise, or again, like I said, just physical activity. But we have some indication that all of those are beneficial, and I would certainly recommend that the concept of kind of moving more and sitting less should be something that everyone should try to aspire to, and most importantly, engaging in things that make you happy, or that makes the individual happy. People enjoy doing recreational sports or doing leisure activities, gardening. These are all things that, they can often get your heart rate up, and they keep you moving and minimize your time spent sitting. So I would certainly say that having kind of a well-rounded program certainly can be beneficial. And related to that is just walking. Walking is one of the best exercises that we have. This is a picture of some individuals with HD walking in the Netherlands. And in the Netherlands, they have a very active walking program for people with HD, where they walk on the dunes in the very northern part of the country. And if you can tell there in that picture, people are walking actually on sand. And one of the benefits of walking on sand is that if you fall, you are very unlikely to get hurt. And so they keep people walking, for very long into the disease process. And the patients there are functioning and very mobile for a very, very long time period. So I've always looked to the Netherlands as one of our sort of anecdotal evidence about the benefits of exercise and in particular walking. And aerobic and strengthening. We do believe from our Exert study that aerobic exercise in particular has the potential to have an effect on disease-specific motor function. Coming from sit to stand is one of the simplest exercises. We do it every day, but practicing it and engaging in that and other kinds of strengthening exercises, we think can be really beneficial for disease-specific motor function. And then the last thing I would say is if you are interested and you do happen to live near near either of these sites, we would love to have you join into the studies. And we are planning future studies down the roads that we will keep updated on HDSA and also HD Trial Finder. So we would certainly encourage you to participate, and also even participating and enroll really helps for us to be able to gather data that's related to the benefits of physical activity and lifestyle. The final last thing that I just want to talk about is physical therapy in general. So a lot of what I've talked about has been exercise and physical activity, where you certainly could do it on your own, or you may have a coach or a trainer work with you. But I want to give a little bit of a push towards physical therapy as an intervention. Most of the time when people get referred to physical therapy, it's because something has really gone wrong, or something's problematic, or maybe people are falling or having a lot of balance problems, which is definitely great. And we also have a role in these earlier stages to try to help with helping people to engage in exercise. But I want to emphasize that we have done some things along with my colleagues, Nora Fritz and Ash Rao, Deb Kiegelmeyer, Ann Kloos, Monica Bassa, and some other individuals, Linda Hart and Judith Carrier, work at Cardiff University, where we've looked at the systematic review, but also we are developing new clinical guidelines based on this review, specifically for physical therapists, so that they can better use evidence to be able to engage in interventions with people with HD. I think one of the difficulties with that I hear a lot from patients and families is that, maybe they went to a physical therapist, but they didn't really know about HD. And now we do have this guidance document that's here, and this is being updated because we're developing these new guidelines based on the review, So now there'll be the resources so that any physical therapist can access this information and know what the current best evidence is for working with people with HD. And I would certainly encourage that if people have any concerns about balance or walking or physical fitness, that you seek the services of a physical therapist, because we certainly know it can be very beneficial. And the last thing I will just say is to stay in touch. We are, you can feel free to send me an email at either of these email addresses. The first one is my lab here at Columbia, and the second one is related to our work that we do at Cardiff University. And we're also on Twitter, so we try to communicate a lot about the exercise programs that we're doing and the studies and anything that might be in the news that might be relevant or important. And just quickly to acknowledge all the patients and families who participated in our studies. A lot of people give of their time freely and conduct exercise studies and do all sorts of things to help us to be able to better understand this. So we really appreciate that. And to Monica Bessa, who I do a lot of this work with at Cardiff University, and to all of the funding sources that we have, most especially the Huntington Study Group and the European Huntington's Disease Network, as well as the Jacques and Gloria Gosweiler Foundation, who funded all of this work. And these are our references, which I will leave up, and you can certainly contact me if you wanted to get any of these papers. I'd be happy to send them to you. And that is it. So, Leora, I guess I'll just turn it over to you now.
Great, thank you so much. That was really informative, and it's great to be able to hear what the kinds of very well-controlled research on exercise that you and your colleagues are doing. Maybe you could put it back on the slide that shows your contact info. So a couple of people asked about that, but we also have some other questions that have come in. So one person asked, while they know that this is individual dependent, what do you think would be sort of a beneficial aerobic target heart rate, or maybe some other sort of target parameters for somebody who's starting to work out who has HD?
That's a fantastic question. Yeah, and I'm so glad they asked that. So what we recommend right now is exercise at 65 to 85% of heart rate max, and that is a kind of in a moderate range. Even 60 to 70% is in a moderate range. Once you get up to 80, 85, 90, that tends to get more towards a high intensity. In our studies, in the Exert study that I showed, everyone who was in the study was able to get at least at 60% of their heart rate. And those individuals were able to show benefit. So I would say that 60% of the target of the max heart rate is a minimum. And I'll just give you a quick overview if you don't know how to calculate what your max heart rate is. One, you can get it from an exercise test, and that's the most accurate way. Another very kind of quick off-the-cuff way is 220, just the number 220 minus a person's age. So if you're 40 years old, your max heart rate in theory should be somewhere around 180. And so if you take 60% of that, I can't do it right now, but that number would be your target heart rate. And so you can calculate that range based on that factor. So we would certainly recommend 60 as a minimum, going up to anywhere around 80 or 85. I don't feel like there's enough research right now to recommend going much higher than that. But we are definitely looking into that.
Thank you. Great. So someone else wants to know, and we're also interested in how one might get a copy of the physical activity workbook version 2.
Okay, so the slight issue with doing research is that it really limits what we're able to distribute because we're still evaluating it. What I can say is that if you contact me, I can share with you some documents, especially the first version of it, because we're still testing the second version and working through it, that we're not able to sort of legal issues prevent us from distributing it. But if you want to contact me, I can give you sort of the first version, and I can talk through, give you a whole bunch of other things that would be very similar and I think helpful for that.
Great, thanks. We have another question related to nutrition. Someone's wondering whether in any of these studies there's an emphasis on nutrition. I imagine that when people begin a new exercise regimen, their nutrition needs might change, and nutrition needs change certainly as in different phases of HD. So if you could speak to that a little bit, that would be great.
That's another great question. So I will say that in all of these studies that I showed so far, we do not have a specific nutrition intervention. In our current study, PACE-HD, we are giving every individual a nutritional advice about, which I think actually a lot of it comes from HDSA, the general nutrition advice about HD and the importance of proper nutrition and healthy eating and diet. And I think that there's some other people. I just actually met someone from Australia who I believe is looking at a more comprehensive lifestyle intervention that includes diet. But what I will say about our Exert study was that individuals in the study actually did lose about 2 kilos on average in the course of the study, which was surprising to us because, and as you might imagine, not a wanted effect for us. So many people do exercise to lose weight, but in Huntington's disease, it's not something that we wanted to happen because we do want people to maintain their weight. We thought with exercise, because oftentimes when people are engaged in aerobic and strengthening exercise, you actually get an increase in your appetite, and some people actually, often people gain a little bit of weight, and certainly if they're gaining muscle mass, they're going to gain weight. But that did not happen. So in our new study, we are more carefully paying attention to this and making sure that people who are engaging in exercise are being sure to have the proper diet and compensating for that. But I think it's a really important study that needs to be done to look at the effects of diet, and I believe that they might be starting something in Australia relatively soon.
Great. We have another question that's it's a little more specifically related to equipment. Is there a particular type of stationary bike that you would recommend to somebody who's interested in that for HD, or any other type of kind of beginner's exercise equipment that you recommend as a?
I do. Yeah, I'm going to have to look it up because I can tell you the exact bike that we have used. So the 2 bikes that I showed there are both a certain kind of bike. I'm just going to pull up the name of it really quickly. But one of those is it's called a regular upright bike, and the other is a recumbent bike. So a recumbent bike, you sort of saw that individual. Let me go back to it. Yeah, so you see the individual there who's sitting back and has his back supported, and the one up above, which you're seeing the video of now, doesn't have the back supported. So either one of those are fine. I think it's just also a matter of balance and how comfortable someone feels. Sometimes with the back supported, people feel better, but the key piece is just making sure that it's something a person feels comfortable with and can pedal with effectively. So if you give me 1 second, maybe we can ask another question. I will get the name of this up and I can give it to you.
Sure. Some people are asking us about how they can participate in the study if they're in New York or LA or at any of the European sites. So again, that information is available on HD Trial Finder. You can go to hdtrialfinder.org and take a look at that. And as far as the contact info that was up, those websites from the UK and also from Colombia have contact information for Dr. Quinn and others on the rehabilitation teams there. So have you, Dr. Quinn, have you pulled up your?
Yeah, I might. Oh, wait, no. Here, I think it is here. Yes, here it is. It's called a Proform, PROFORM 440 ES. So, and I know that you can even just get it on Amazon.
Great.
Yeah.
Well, I think.
So
I have a question, Lori. This is George from HDSA. I'm really intrigued by the result that you showed from the Engage-HD study on cognition. And as you know, there's literally nothing we can do, and no therapies currently available to improve cognition in HD patients. And you showed a significant improvement in cognition. And I was just wondering if you looked at how long did the effects of exercise last on cognition? Did they last for months? Did this return back to baseline after a week if the exercise regimen ended? Did you look at that?
Yeah, so we did not. These were just pre and post design. So we just did an immediate and then a post assessment. With that one, we did have a follow-up a couple of months later, and I believe that cognition did maintain, but it wasn't a long enough follow-up. I'm just going to show you the PACE trial design and one of the reasons why this is such an important study for us. So we have in this study a much longer intervention. So we have a 12-month intervention. And the important thing with this is it's linked up with Enroll, but we're also having a 6-month interim assessment. So if we show an improved cognitive effect here, we'll be able to understand, one, if it at what point it starts to change, and two, if we can maintain it over any period of time. The bigger question then would come down the road is, would that be maintained, right? Once our direct intervention was removed. Every indication from us is that any benefits that we get from the interventions do tend to be lost once the intervention is removed. So if we have a very specific intervention where we're working with someone, once we stop working with them, then they tend to fall back and not participate in the exercises. That's one of the reasons why we're so focused on this coaching aspect. But also, we want to be able to do these studies so that we can show it might be that we need to have, that insurance companies would be, it would be money well spent to have someone have a physical therapist a few times over the course of the year to help continue their engagement in exercise. The other really nice thing about this, George, is that since this study is linked with Enroll, we have a natural way of assessing them a year out and 2 years out. So all of these people who are getting this intervention, we can follow them now for the next however many years and see if they do have any effects, how long those effects last for, does this change the course of their disease over some period of time. So that's the reason why we're doing this study. But it's a great question, and to be honest, it is just one finding. We don't know for sure that it has an effect. We really have to for any finding, we have to prove it in multiple studies to confirm that it's actually a true finding. But we were really encouraged by it.
That's great. Thank you, Lori. And so you had mentioned, and maybe you said this when you discussed the PACE study, and I apologize if I missed that, but just now that PACE is linked to Enroll. So is it prerequisite for being in your PACE HD study that you are also a current or Enroll participant?
You don't have to be a current one, but you will have to join Enroll in order to do it. So yes, it is a requirement. We've had some people who were interested in PACE and then they joined up in Enroll in order to do it. But a really key part of this is so that we can avoid duplication and that we can have this longer term tracking of patients. And as you know, Enroll is a platform study to be able to build other studies like this off of. So, yeah, it's a critical part of the study design.
So we have, maybe we'll take one more question and then wrap things up. Someone is asking about home physical therapy for late-stage HD, and whether you know anything about insurance involvement and Medicare in that, and maybe some of your recommendations.
Yeah, so it's a good question, and I didn't focus on late stage, but there's a lot of certainly support for physical therapy in the later stages of the disease. In theory, Medicare should pay for late stage physical therapy, even if patients are not making improvements. And I know there's a lot of discussion about Medicare sort of talking about that patients need to be improving and setting goals, but in fact, it is not the case. They should pay when patients are in the later stages, and as long as the intervention that's being delivered is a skilled intervention by a physical therapist and has to be delivered by a physical therapist. And I think that there's a lot of arguments for that. So we have written actually a lot of letters and support to make sure that people do get the services that they need in the later stages. And I think physical therapy is a really critical component of it. So if that individual who asked that, or if anybody has any questions about that, you can feel free to email me and I can point you to some other resources about that.
Great. Well, thank you so much again, Dr. Quinn, for sharing all your expertise with us today. And thanks to everybody for joining us once again. You can view this again at hdsa.org/researchwebinar. And you can definitely reach out to Dr. Quinn with any further questions. So thank you all so much for your interest, and we'll see you soon. Bye.